Hi, good afternoon everyone. I'm Dr. Vijaya Sarathi. I'm an endocrinologist from Bangalore, currently working as professor in Vaidehi Institute of Medical Sciences and Research Center. I'm going to discuss briefly now on congenital hypothyroidism. Congenital hypothyroidism refers to deficiency of thyroxine production for various reasons which manifests since birth. It's it's the most common cause of preventable mental retardation. The prevalence of congenital hypothyroidism in India is much higher than what we see in Western countries. But despite that, the newborn screening which detects congenital hypothyroidism in India is not very active. In fact, if we do clinical examination at birth, we could hardly pick up less than 10% of the neonates who have congenital hypothyroidism, which would lead to delayed diagnosis in them. Later we diagnose them, later we start them on treatment, they are going to suffer from more severe mental retardation. That means we need to diagnose them as early as possible so that we can initiate treatment in time and provide a good developmental outcome and good IQ for the neonate. But how can we do this? As I told earlier, it is the newborn screening. We are going to check the biochemical test and checking the thyroid status of the neonates, every neonate for that matter, to check whether they have hypothyroidism or not. So what is this newborn screening? Newborn screening includes that checking each and every newborn born anywhere, either in the hospital or at home, to check for the thyroid status. It's done by two methods. One, either collecting the cord blood as soon as the baby is born and checking their TSH, or by collecting a heel prick sample, but typically after 48 hours of birth, and checking the TSH. The cord blood collection offers advantages because the baby will not feel the pain of the prick since we are collecting the sample from the blood, right? And it's very easy to collect. And also, so even you can run the sample in a local lab, as we don't require any particular special labs to check a TSH. Whereas the heel prick sample requires some specifications that we can't, heel prick sample cannot be run in a local lab. We need to run the sample in a specialized lab. Of course, since we have to prick the heel of the baby may feel some pain. It's quite difficult, in fact, to collect the in a right manner the heel prick sample. Whatever is the sample, it may be a cord blood or a heel prick, then we usually check the TSH in this. Of course, there are other strategies such as checking T4, but the one which is most suitable for India is actually a initial TSH screening, also called as primary TSH screening, because it diagnoses most of the patients with congenital hypothyroidism, though it really misses the infants with central hypothyroidism. On the other hand, T4 screening, that is primary T4 screening, though it identifies or detects the central hypothyroidism, it misses a good number of patients with subclinical hypothyroidism, and also there are high rates of false positive with the T4 screening method, because it's a very common situation to have low T4 with a normal TSH in preterm infants and infants who are sick for any reason, right? So, and once we do a TSH either from the cord blood or the heel prick, then we have to interpret the results, and if the TSH is more than 20, then we say it's a positive test and we recall them for a second test, right? Where in a second test we again can collect a heel prick sample, or we can go for a confirmatory venous sample, right? Once we obtain a confirmatory venous sample, if it's more than 80, we should immediately start them on treatment. But if it's more than 20 in a neonate who is less than 2 weeks old, or more than 10 in an infant who is more than 2 weeks old, then we need to consider them as hypothyroidism and treat them on with thyroxine, right? So, and in these patients, when we decide to treat, we need to treat them with a good dose of thyroxine, which is around 10 to 15 micrograms per kg, where we are trying to normalize the T4 as early as 2 weeks and to normalize the TSH as early as 4 weeks. So, and once we start them on treatment, we have to regularly follow them up, like maybe once in 2 months till the age of 6 months, and maybe once in 3 months till the age of 3 years, and later it could be at a less frequent interval such as 3 to 6 months till the child completes growth, right? So, and finally, it's important that every newborn who is born in India should be screened for congenital hypothyroidism, so that we prevent the possible mental retardation in all these infants, which could be prevented with very minimal efforts, and probably we require a lot of support for this from the government as well to start this programs. Thank you.